thank you very much for all the speakers. So, I'm going to give you an overview about the BOA strategy for us as surgeon. I have no conflict of interest. What is the target of BOA? I mean, BOA is provide national leadership, unifying focus to endeavor by caring patients, supporting surgeon, and transforming life. But we are here to supporting surgeon, which you, the SAS surgeon. So what does a surgeon expect from BOA as a professional body? I mean, this was from the last year in Brighton, from the SAS surgeon. We need protected time for education, we need judge progress against defined criteria, we need to provide feedback, enable support to be directed as required, clear assessment method. Also, representation of the BO Council has happened, wider use of ISCP for SAS doctor, and actually now there is support for SAS doctor and ISCP. CSER courses, we're talking about that, we're going to do that, and maybe instruction courses or short period of fellowship toward FRCS. So, overview of BOA strategy for SAS surgeon, I put it in 5 domains. BOA membership, good practice guide for SAS surgeon, educational program, SAS surgeon webpage, and SAS surgeon fellowship. BOA membership, why do you need to be a BOA member? Actually, if you're not a member, we cannot hear your voice. You can't just say, oh, BOA haven't done anything to us. We need to be a member to raise your voice on that. And actually, the board has been supporting the membership, and I keep telling them, well, it may be a high membership fees, why not to do an introductory fees? And we come with the idea about 3 levels of SAS surgeon about the year of experience. And I think this probably reflects the practice and the whole heterogeneous group of SAS surgeons. That's level 1, probably got 5 or 10 years experience, level 2, between 5 and 15, and the senior people, more than 15 year experience in the field. And we make this figure for the membership. And actually, the last one is 274, is probably 1/3 what the consultant paid for the membership, which actually is very, very good to attract SAS surgeons to be a member and to hear your voice. And people asking, what is the benefit of BOA membership? Yes, free attendance of BOA annual congress, annual membership handbook, reduced rate for training event, reduced rate for professional indemnity, eligibility for the fellowship. If you're not a BOA member, you cannot apply for BOA fellowship. People ask, what about journal? Is that includes the journal or not? Actually, it's not, and we separate the member fees from the journal. But Mr. Robert Marshall, who is the chairman of British Editorial Society of Bone and Joint Surgery, who is just sitting here, send me this, the next 4 slide. What journal they have? They have the Bone and Joint Journal, not called GBCS anymore, it's Bone and Joint Journal. Print one is 12 issue, there is online, and there is app as well. Also, the one I like it is Bone and Joint 360, and it provides very concise expert summary of all the global orthopedic literature. And I like to read it between my cases and see it, really very good. And you have it printed online. Also, we have Bone and Joint Research. We have Bone and Joint Journal app for Apple and Android as well, free from the App Store, iTunes, Google Play. You can read the full text article on your phone, iPad, or tablet. So what is the offer? It's coming free subscription of both DGG and DJ 360 print electronic for all SAS surgeon member who joined the BOA for 12 months. Not only that, after the first year of free subscription, we'll continue to have a journal subscription to the same rate as a trainer, very heavily discounted. So, encourage you want to be a BO member, second, to have this journal. And if any question at the end of the session, Mr. Robert Marshall is here, you can discuss with him. Go to the second domain, good practice guide for us as surgeons. People keep asking is, does the BOA as a professional body give us any good guide, what we do, what we're doing? And I put it over a few items: session allocation, surgical logbook, coding for clinical practice. And I came with the idea was called level of supervision. I call it graduate supervision scale. Session allocation, probably you hear David Lem talking about Caesar. You have to do at least 3 operating sessions and 2 clinic for the last 6 years to be approved. So probably in the guide should be allow SS surgeon full-time contract of at least 3 operating theater session, 3 OPD including fracture clinic. I have some SS surgeon come to me and say, Mr. Morgan, I work in my unit, out of my 8 session, I do 7 clinic. And why is that? Also, the clinical director said, I'm not entitled to give you anything, you're not a trainee. So some people just doing orthopedic medicine despite they are, and they don't have a support from the professional body. And probably we need to give a guide rather, it's not a term and of contract, it is a guidance. Also, on-call duty will depend on the type of on-call rota. Some of us are surgeons doing registrar rota, some of them are a consultant rota. Surgical lookbook. I encourage every SS surgeon to have a surgical lookbook for annual appraisal. Either you apply for Caesar or not, I still keep my surgical lookbook till now. I'm guiding for average operation per year for annual appraisal. Coding for clinical practice. This is another problem for SS surgeon when you're coming for appraisal. You do a clinic with a consultant. There are 25 patients in the clinic. He sees 15 and you see 10, but all the 25 go credit to the consultant. And nobody knows that you have seen 10. So probably encourage a hospital trust to involve the name of a surgeon or an assistant in theater if you do an operation with a consultant. Actually, this is transparency and probity issue. The patient need to know who do you see. Because they say, I see Mr. X clinic, but actually it is Mr. Y who's an SS surgeon seeing that it all the management plan. This will help also in process of appraisal for SS surgeon. What about level of supervision? As I said again, you need to have a supervision or not. I'm senior, I'm junior on that. And I put it, this graduate supervision scale, coming from full supervision, limited supervision, distance supervision, autonomous practice, education supervisor, and clinical supervisor. So how can we do that? How can we say, Mr. X will do this one? I come with this idea about, let's compare it to the training program, let's come together as the same. So there's some specialty doctor doing level of ST3 and ST4. These need a full supervision. There's some staff grade specialty doctor, maybe at the level ST5 and ST6, still need a full supervision. Some senior staff grade, maybe ST8 or junior consultant, probably need a limited supervision, maybe consultant sitting in the coffee room, they can do this one. Associate specialist doing consultant work, probably need a distance supervision. So the clinical director just keep an eye, what's he doing over the department. And the easy one, some associate specialist with Caesar, they're already on a special register, so probably this work with autonomous, and also they can be clinical or education supervisor as well. So probably just an idea, how can we structure or stratify the SS surgeon? Education program. We have a BO Congress, and actually now become a traditional, we have an SS session in the BO Congress, and I'm sure it will continue and be developed. Hopefully we can have like an orthopedic review day for SS surgeon, just to review courses, people keep up the knowledge. One day to get some knowledge about knee, ankle, upper limb. Also to access to education material to the BOA webpage. Also, we suggest to have an SS surgeon webpage, which include all the education material, but what's important, we have an SS surgeon forum. We need to communicate better. We need to listen to you. We need to raise your concern if you have a concern. And the last thing is SS surgeon fellowship. And I mean, here talk about SS traveling fellowship, and I encourage all of you to apply. And actually, I was sitting in the panel interview last year in January in Manchester for traveling fellowship, and I said, why not to have 1 or 2 fellowship for SS surgeon? I said, it's open for all SS surgeon, please apply, you will have a support. Also, I suggest to have like SS home fellowship, which used to be like a short fellowship, like an observer fellowship, someone doing shoulder arthroscopy, someone doing revision hips or what. He need to go with some senior figure in the country. Why not to make a short fellowship, home fellowship, 4-6 weeks, rather than travel to Seattle and we have experience in this country. Why not to use it and people gain this experience? Also, we suggest an education committee. We're going to have in 2016 an SS surgeon BO survey. The aim, when you have a desert data about your job plan, training, your education need, we need to listen to you. So I'm preparing a survey, I'll discuss it in the education committee, and hopefully come out in 2016, and depend on the result, we need to listen to you. So I think there is a light at the end of the tunnel. I still believe that a surgeon career route in trauma orthopedic surgery is clear, wide, and attractive. I believe value as a surgeon require teamwork. That means together everyone achieve more. That's what I call it, teamwork. Thank you.